right, recording. All right, we have a lot of new faces today. Welcome, everybody. Hello and welcome to the George and Fahey Center for Healthcare Innovation, CHI's December Patient Engagement Lunchtime Learning series for the 2025-2026 academic year. Today's session is entitled Fireside Chat, Engaging Patients in Ethical Questions, Lessons from Marginal Kidney Donation Research. My name is Maxa Sawyer, one of the patient engagement consultants on the patient engagement team at CHI, and I will host the session today. A few housekeeping details before Carolyn introduces the panel. The PAL series is accredited by the Royal College of Physicians and Surgeons of Canada as a group learning activity. It may also be eligible for credits toward requirements of other professional bodies. We will have auto transcriptions enabled, which can be toggled on or off at any time using the captions button at the bottom of your screen. One of PAL's goals is for the lunchtime learning to be engaging and interactive. Your participation is encouraged and will provide valuable insight and learning opportunities for both the audience and presenters. Please submit any questions or comments using the Q&A feature, also located at the bottom of your screen, and we will be curating them. Maybe we will be talking about them during the discussion, and if not, we will get to them at the end of the session. With that, I would like to invite Carolyn Schumann, Provincial Patient and Public Engagement Lead, to say the land acknowledgement and introduce the fireside chat.
Hi, everyone. Thank you so much for the introduction, and thank you so much to everyone for joining us today. I'd first like to begin by acknowledging that myself, our speakers, and the Center for Healthcare Innovation are located on the ancestral and current day lands and waters of the Anishinaabeg, Innunuwak, Unshinnuwak, Dakota Iote, and Dene Suline, and on the national homeland of the Red River Métis. And in northern Manitoba, we acknowledge the ancestral lands of the Inuit, and we gratefully acknowledge that our water is sourced from Shoal Lake 40 First Nation. We respect the treaty, the spirit, intent, and language within the treaties that were made on these lands, and acknowledge the harms and mistakes of the past and the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare systems, education, justice, government. As we come together for a conversation about engaging patients in ethically complex and emotionally charged research, this acknowledgement reminds us of our responsibility to approach engagement with humility, reciprocity, and care. It calls us to center the voices of patients, families, and communities, including those who have historically been excluded from decisions about their own health, in how we design, conduct, and apply research, as well as inform health systems design. And today's session is very much grounded in that commitment. So today's fireside chat, engaging patients in ethical questions, lessons from marginal kidney donation, explores how lived experience can deepen ethical awareness and help clinician researchers navigate questions of acceptable risk, vulnerability, and shared decision making. We'll hear about what meaningful engagement look like within a study that asks patients and families to reflect on the realities of accepting a kidney that may carry higher risks. I'm very pleased to introduce our lovely speakers today. Dr. Aaron Trachtenberg is a transplant nephrologist and assistant professor at the University of Manitoba. He completed his Doctor of Philosophy in Clinical Neurosciences at Oxford as a Rhodes Scholar, followed by medical training in Manitoba, Calgary, and Glasgow. He now serves as the Medical Director of Quality and Innovation for the Adult Kidney Program with Transplant Manitoba. Joining him is Dr. John Buchanan Bond Jr., a retired professor from the Department of Family Social Sciences at the University of Manitoba. John brings deep lived experience with advancing kidney disease, the loss of his wife Sharon, and ultimately receiving a kidney transplant in 2022. He has contributed his insight as one of Dr. Trachtenberg's patient partners, helping shape this project with compassion, honesty, and wisdom. And our moderator for today's session is Maxa Sawyer, the Center for Healthcare Innovation's patient engagement consultant, and is on our team. Using her background as an ethnographic qualitative researcher, educator, and storyteller, Maxa works with clients to create safe, reflexive spaces. So we're honored to have all of you with us today, and I'll now turn it over to our moderator, Maxa, to begin.
Thank you, Carolyn. We would like to start with Dr. Aaron Trachtenberg, giving us an overview of his project, and he will be sharing a PowerPoint with us.
Okay, thanks very much. Hope you can see the slides all right and hear me. I'm recycling a talk from the latest Canadian Society of Nephrology meeting, partly because it's really identical to what I was asked to talk about, but also because I am proud that some of this, what started as very local Manitoba-based engagement, has gotten attention in the transplant community at large. I don't have any conflicts of interest related to this project or any others. And so I just want to spend maybe 5 minutes giving the rationale for the project that we set out to first engage patients on and then turn into a clinical program. Basically, I think we all know this intuitively, but there are not enough organ transplants, and that's why we have wait lists. And the wait lists can be long, they can be hard on patients, and unfortunately, a certain number of people die every year waiting for a kidney transplant. I'm talking strictly about kidney transplant here, but there's similar concepts in other solid organ transplants. So whenever we have a scarce resource, we have to think about how to allocate it. And that's true for all resources in medicine. But when it comes to kidney transplant, because it involves a real sort of contract with society as a whole, because everyone is asked to consider being a donor, and anybody in theory could be a recipient if they have a health condition, we do spend quite a bit of time thinking about how we can allocate organs and focusing on three primary ethical principles. So utility would be the first one. Basically, optimal use of this limited resource. How do we get the best outcome from a transplant? Now, I could spend a whole hour talking about how the answer depends how you define a good outcome. If you talk about just how long the kidney lasts, that's a different conversation than, quality of life of the recipient or ability to participate in life of the recipient. So we are constantly trying to get the best outcome out of each transplant, but also making sure that we're balancing justice and equitable access to this resource. And at the same time, respecting individual patients' choice to either accept or decline a certain offer. So prior to this project, this is what our Transplant Manitoba allocation algorithm looked like. It's a little complicated, but we were one of the first, maybe the first program in all of Canada to just publicly put our allocation protocol up on our website, try to be transparent and accountable in how we allocate. Because it wasn't that long ago that an organ donor would come up and a group of doctors and maybe a nurse would sit around with a list and just kind of go through it and say, this looks like a good kidney for this person. And there's obviously ethical concerns around that. And so every program has now moved to a kind of transparent algorithm that is a shared health policy. So I'll draw your attention to this middle part here, where we're just talking about normal priority, meaning that there's no recipient that fits some of these higher priorities. We use a score called the KDPI, or the Kidney Donor Profile Index, to estimate the so-called quality of the kidney, really an estimate of the longevity of how long that graft is going to last. And then we try some form of utility matching, meaning the kidneys that are going to last the longest should go to younger people that need one to last longer. The kidneys that maybe have reduced longevity are going to go to older patients who do, they need a kidney to last the rest of their natural life. They don't need it to last 40 years. And then in the middle is sort of just if anybody's eligible. And then each individual on the list has a priority score that's heavily weighted by their wait time, but also influenced by some issues around immunological matching. Now, the KDPI is this risk score that looks at a bunch of factors to do with the donor and tries to predict, compared to the median donor, or let's say, just the typical donor in a previous year, how is this donor kidney going to last? And it converted it into a score. So the KDRI is the raw score. And let's say it says 1.28. That means that this specific donor has a 28% higher graft failure rate than that of the median donor. And you can calculate a score for any of these donors that have happened in the past and convert it into what's meant to be a more intuitive but still kind of confusing way of putting it, which is this KDPI score, which just maps it onto a percentage. And so a donor with a KDPI of 85% has a relative risk of graft failure that's higher than 85% of all recovered kidneys in the previous year. So you can think about it as the worst 15%. And what happened is we were not using transplants that had a KDPI over 85, especially in the so-called donation after cardiac death. And that wasn't just us. After the launch of this score, there was a lot of work showing that this harmful labeling effect happened, where people started drawing arbitrary lines in the sand and not using these kidneys. It became such an issue that there were consensus statements almost, 7 or 8 years ago now that we need to think about how we're going to reduce kidney discard. And then work started coming out showing that, yes, these transplants may not last as long as a younger transplant, but that accepting one of these is still associated with a better outcome for older patients who are facing a long wait on a wait list otherwise. And so local barriers were kind of numerous. There was behavioral psychology, about how we make choice that is interesting, but I don't have time for today. Our allocation mechanism, because we were very transparent and it would always go to the person at the top of the list, it was difficult to offer that sort of quote unquote lower quality kidney to somebody who's at the top of the list. Because for that individual, they could just wait a couple more months and get a better kidney. We needed flexibility in our allocation to offer these to people lower down on the list who will actually get the benefit. There also was some good work out of Quebec like 5 years ago now showing that there was still a real kind of lack of respect for autonomy and paternalism in this situation, where basically the medical providers thought that it was a medical decision what kidney is right for what person, and it was up to them to offer it or not offer it, and that the patient didn't really have either the skills or the desire to be involved in that decision. And that was some interesting qualitative work that kind of informed how we approach this. And then concern around program metrics is more of an American issue. So with all of this in mind, we set out to actually create a dedicated high KDPI transplant program. We wanted to reduce kidney discard, and we needed it to be acceptable to patients and providers because it was going to be a big change. We worked together, and we'll talk about that. We published, how we went about doing this, and we effectively built a clinical program that's been in practice for 2 years now. Where we have sort of the concept of an alternative donor pool, and we will allocate those to pre-consented individuals that have had time to think through this and agree with the risk-benefit trade-off and sign up for this program. This is kind of how we think about the risk for the candidates. And importantly, from the engagement work, we were able to create some really helpful educational material that had patient input to make sure that it was sort of being explained in an accessible manner. This is just sort of a general overview of the program. This is supposed to be kind of a decision-making tool that shows the pros and cons of waiting on the standard list or enrolling in this optional, what we call age-targeted list. We launched the program in 2023, and when I made these slides a few months ago, we had done 13 new transplants from 8 donors, which doesn't sound like a lot, but over that whole period, we only did 128 deceased donors. So this increased our deceased donor rate by 10%, which is pretty actually unheard of for a single intervention to increase transplant rates by 10%. So we're happy with how it's going, and now we're in the safety monitoring phase to make sure that it's working out. So I will stop there and we can move on to the questions.
Thank you, Erin, for sharing all that. Erin, can you share an example of how patient partner input shaped the direction, design, or framing of the research?
Yeah, so I mean, I can tell you maybe first how I even went down the route of patient engagement, because when I started this project, I was very much looking at all the evidence that was out there from other countries that were already using these kidneys. And I had a plan of putting it more into a mathematical sort of economic evaluation to determine some thresholds where, when you're this old, you should take one of these kidneys. And this is what the evidence shows. And I was talking to a mentor from Calgary who has done both economic work and now is more involved with some kidney groups that are focused on engagement. And he basically just said, you can do all of that, but the real question will be, is it acceptable to patients and is it acceptable to providers? And that could be very different than what the math sort of tells you. And that was just a really eye-opening way to approach it. And so the biggest way that it ended up driving everything was that it's one thing to look at research studies, but it's another to talk to even just 10 people who have experience with needing to make these decisions and understanding how they might weigh this, how they might choose to participate or not participate. And I found it just much more impactful and convincing when trying to launch a program to have that input than have read, 10 more research studies about it.
Thank you. And John was one of your patient partners.
Yes, he was. Very helpful patient partner.
And John, how was your experience as a patient partner for this program?
Well, first, I was really pleased to be asked to be part of it because life goes on. It's nice to be able to use my skills, but also because of my life experience with this, I found it pretty engaging to have a number of other people who are either on dialysis or otherwise involved in it to hear other people's stories um, and what they were experiencing, and watched how my life had changed over time from home-based dialysis to center-based dialysis to then transplant, and be able to think about the implications of each of those and how those different stages affected my life, and be able to add some of that perspective to it, but more to hear other people's stories. And Erin had done a really good job of selecting a variety of different people to be able to help inform in the development of the educational materials, and that was extremely useful to to go back and forth, not only discussions orally via Zoom meetings, but also textual things that we could look at, revise, and submit back.
Can you both talk a little bit about how this safe space was created that allowed people of different backgrounds and different conditions to talk to each other in a safe and supportive way?
Well, so this was my first real formal attempt at patient engagement, and Carolyn and the CHI and the prep award that I got like helped me a lot actually get the initial um, meetings up and going. You know, just like even simple tools like using an icebreaker and just a few documents I read about some like the power imbalance that can be there and being aware of it. And then, I mean, I'll let John comment on this, but at first I was a little disappointed we were gonna have to do it all on Zoom because it was during the pandemic, and we did it on Zoom, and then in the end I thought that that maybe helped people feel more comfortable because they were sort of in their own homes. Sometimes you could
Mm,
see that like their spouse or someone else was around as well. And I really liked that part. I don't get to see patients. They weren't my patients, but they were speaking from the patient perspective. I don't get to
mm,
see them in their homes ever. I see them when they're sick or maybe in a clinic. And to see people's homes, to see just like John has right now, photos up in the background and just get a reminder of what's at stake here, people's full lives. I really
mm.
like that. But I'd let John comment if being on Zoom made it feel more safe or awkward and difficult to chime in.
Well, I think that if I'd been asked to be a participant and come into a meeting, I might have been more likely to reject doing it just because of
Interesting.
the inconvenience to start with. It
Mhm.
was really
Mhm.
nice to be able to sit here in my study and talk and feel comfortable, but also to listen to other people. So, one of the things I was impressed by was that there was a fellow who was living in a remote area of Manitoba, several hours outside of town, and to listen to his experience, even how difficult it was to go for dialysis, where you'd have to drive an hour and a half each way 3 times a week and listen to that. So I'm thinking to get his perspective on something like this would have been almost impossible. Um, so the variety of people are really important, and I think it's for those that have the ability to do Zoom meetings. You'll cut out people when you can't if they don't have this capacity, but you do it gives you a chance to expand things in this province throughout the province if you need to. It might have even been interesting to get people from northern Manitoba, from reserves or something. So there's a whole lot of possibilities that can open up with Zoom. And I think it was a good approach as opposed to let's all get together over coffee around a table, drive to town, park, struggle to get into the hospital, find the place, sit down, get out. For what? And the interchange was really good via this as well. And then the follow up via emails and things was also good. So I think it was a very effective approach.
So I'm hearing a few things. I'm hearing that from Aaron's perspective, that being in the home from a virtual perspective allowed Dr. Trachtenberg to see the patient from a whole different side. The humanness sort of get that subjective bias that we don't always think about having, seeing that. And when we see how we see people, we can sort of start turning that on our head and what are my biases that apply? And then, John, I hear from you that this opportunity allowed you to meet people who had both the same experience needing a kidney donation, but had very different experience, maybe because of their location, their space, convenience. And also that online component allowed you to um, participate in a way that meeting for coffee might not. Aaron, what surprised you most about engaging patients and families in this project in terms of your understanding of equity, inclusion, and ethical research?
Okay, surprised me. I think what surprised me the most was how wrong that study I mentioned, the qualitative one um, that it surveyed all these transplant providers that are involved in screening kidney offers and how they all felt that this was a medical decision and it was up to the doctor and that patients didn't really either have the capacity to weigh this or want to. I thought these were like pretty heavy concepts. Even in the first year or two, like I had a whole other provider engagement, right? Where I needed to convince people around here to buy in. And it was a difficult concept to explain, but I thought after one or two meetings, the patients really did understand it. And clearly, kind of the wheels are turning and it's their lives and they're weighing heavy things about, do I want to be off dialysis now when I'm like younger and have more time, or do I want to kind of gamble on the wait list for a better kidney? Like, this is all going on. And I think that maybe just like when we see people in a stuffy doctor's office where there's a clear power dynamic and that they're not, or we're not asking the right questions because the
Mm.
people are clearly capable of thinking about this kind of stuff. And why wouldn't they be when it's their life?
So, power dynamic.
Yeah, I mean, just the kind of difference that we might not even be aware of when we're seeing people, in a clinical setting as doctor and patient compared to what we get out of them when we're meeting as partners on a shared project.
John, were you surprised about anything as a patient partner?
Uh, Not surprised, but appreciated of it. To
Mm.
be asked to start with was an important thing to say what I think is important and to be listened to. And when suggesting revisions, for example, to have them accepted but circulated as well, I think that was really good. And just to follow up on Aaron's comment about seeing people in their own homes, part of my research when I was an academic was did a lot of interviewing of people in southern Ontario on a project involving Mennonites. And my approach was to go to the different homes of the people to do the interviews rather than to try and collect in a church or something. And to be able to sit down at a table over coffee to talk with people, or being up in a hayloft, or standing out in the farm beside a tractor doing the interviews, and people just open up because you're on their home turf. You've not brought them to you; they have the power as opposed to you.
Mm.
And I think people are more interested in talking when they feel that at least it's an even balance. And that certainly came out in the Zoom meetings that went on. I Everybody talked,
Mhm.
and nobody held back. And Aaron prompted for questions and encouraged the talking. So I think it was surprising how well people responded remotely as opposed to what I'd experienced person to person. The same type of dynamic.
It's so interesting to hear you guys talk about how space and meeting people where they're at affects something like donor transplants and donor recipients. I would have never thought that this would apply to this type of work.
Hmm.
What about in terms of marginalized race? Um, did you have a variance of people on this patient panel?
Yeah, I mean, so I had specific groups that I wanted to engage. Um, Now, I was because I didn't have like kind of research ethics, and it gets a little complicated when you're actually trying to like formally study race. So
Hmm.
it's not like I could single out specific people based on race and promise that race was going to be like analyzed, but I wanted as close to an equal gender balance as we could. Everybody was supposed to be 55 and up because it was like that's the target population. But we had a wider spectrum of age, which ended up being super helpful for reasons we can talk about after. And then I wanted some geographic distribution because, as John pointed out, like people that live far from dialysis, they make different decisions than people live real close to dialysis. And that's not necessarily fair. Well, it's not fair, but it's the reality. And so we did have, as John mentioned, someone living kind of rurally. We had one person from Thompson, and maybe John didn't even realize that because it was on Zoom, but they were
Right.
up north in Thompson. And but I did have two three, I guess, three out of, I think we started with like eight or nine patients that were Indigenous, because Indigenous patients are overrepresented in kidney failure, and I really wanted that view.
Hmm.
Unfortunately, as the um, project went on, two out of three of them dropped off. One, because he lived very remotely, and I think just lives a more kind of living on the land kind of lifestyle, not, not wanting to necessarily keep a specific appointment time. There were a couple times where I talked to him just separately because he wasn't going to
Hmm.
come to this agreed upon thing. And just internet connection and all this, right? That didn't
Hmm.
help facilitate that. And then another one developed some health issues and had to drop out. So um, even though I felt like we had a good distribution of gender, location, I think there were some, I mean, there seemed to be some visible race differences between people, but it's not like I was collecting what they identified as per se.
Hmm.
Um, it still felt like it was difficult to capture the voice of maybe those struggling the most with kidney disease,
Hmm.
those trying to balance a job and dialysis, those who are living in very remote places where we couldn't, reliably get internet connection. So I think that's probably just a challenge of engagement in general. I would imagine that people that are able to participate have a bit more of a buffer in life than
Hmm.
people who aren't able to participate.
And I could imagine that would translate into being able to access their doctor's appointments, and receive treatment.
Yeah.
As I'm thinking about it, I'm wondering if even in another type of study like this to do a mixed methods approach where some would be on Zoom where others might be like the individual in Thompson, to have a research assistant up there who could do the interviewing while the person's on dialysis and to go
Hmm.
through the kinds of questions and issues one on one, where it's not so much of a problem. So both in person as well as Zooming, as opposed, and then broadening the perspective a little bit that way.
Yep. Yeah. If I think if it hadn't been the pandemic, and frankly, if
Right,
I
of
had
course,
more funding and
of
like
course,
travel or whatever. But I mean, I think the one way that we countered it was like this wasn't the actual research per se. This was the group to
Hmm.
help make the research, and a big part of that was a wait list survey that went to everybody on the transplant wait list above 55.
right,
And in that, that captured people all over the province. That captured, there
right.
was a component about identifying as, as different kind of ethnic categories, including Indigenous. And so I had a better kind of, I felt more confident that for the survey for everybody, that we had a more representative
Right.
distribution for that in those responses. But that's not the same as the detailed input from the members of the committee.
Right, and that brings up a distinction between patient engagement
Mhm.
and research. And patient engagement is that process of collaborating with people with lived experiences as partners, and in this case, you were doing it partners for design,
Yeah,
as opposed
exactly.
to using the patient partners to collect data.
Exactly. The patient partners were, we started with some big conversations around these topics, like just broad overview. Then we had a session where we kind of narrowed it down a little bit to what are the factors that people are thinking about here? Is it the risk? Is it the wait time on dialysis? Is it how many years of the kidney it might last? And then we built a survey together that was pretty complicated. Like it involved a lot of opinions, but it also had like this economic component where the survey respondents chose between different offers so that we could kind of figure out what factors people were emphasizing and how they choose this so we could build the program to optimize them, right? Like
Mhm.
people seemed really willing to accept one of these if we could really reduce their wait time. So we want to build it that way so that it actually gets used. Because otherwise, nobody, if we make a program that's set up for a way that patients don't want to do it, it's pointless. But the patient partners helped me figure out how to ask these questions in a way that made sense, helped me identify which factors we should study further, right? Because I could have put in 100 different factors, but we needed to narrow it down, help me with the wording and this and that. And in the end, I still feel like the survey was too complicated.
Mhm.
Um, and if I could go back, I would simplify it further, but that was really where the patient, because it was, if I had done it just the way I think about this, I think it probably would have been incomprehensible to patients
Mm.
receiving it in the mail. Like, so it was good. Yeah.
John, have you received surveys like that before?
Oh, yes, often from the medical community.
Yeah.
And
Um,
I think that was part of the role of the patient participants was to help de-jargonize it and to bring it into
mm.
just a common language that people can understand.
Let's talk a little bit about difficult conversations. What challenges arose in talking about topics like less than optimal kidneys, and how did you address them together?
So, I mean, I think there were two things that stick out in my mind. So the first one is just the language that we use at all. That
Hmm.
that's we spent a lot of time on that. It's super important. It's the first impression that someone's going to get when they hear about this. There's huge debates going on even in the transplant community at large, like the national transplant. When we meet up at national meetings, I might call it this age targeted or less than ideal, and someone else is calling it marginal kidney, and someone else. So we can't even agree on what to call it because we want to accurately portray what's at stake here, not make it shiny, but not make it scary either. So
Hmm.
that was very helpful. The names that we ended up using were proposed by the committees. Like, so we called our program the Age Targeted Transplant Program, meaning that we are targeting a subgroup of our waitlist based on age. Like, we're going to offer this to people that are sort of age matched to these donors. And then we just call the donor pool an alternative donor pool. And when I meet with an individual patient, I say, this is a group of donors that we historically were not very good at using. They might be older, they might have a bit of kidney disease themselves, and there are concerns about how long one of these transplants would last. And so we never used them, but lots of other places were using them. And
Hmm.
and we worked with patients here and providers to figure out how we can offer these to Manitobans in a safe way. And we just call it alternative donor pool. We don't say less than this, less than that, because the most difficult thing to explain to everyone involved, the patients, the providers, and now actual patients that are enrolling in this program, is that it's not about the quality of the donor. It's about the quality of the donor plus the chance that you're going to get a better donor, plus the harms of being on dialysis for additional years waiting. So it's not less than ideal. It may be ideal for a
Mm.
75-year-old to do this rather than wait, because if they wait, they'll never get a transplant. So the language, we tried to just keep it neutral, alternative, age targeted. Now, on the subject of age, the biggest challenge was for me was that all the existing like huge studies from Europe or America would say that the cutoffs where people should consider this is like 55. And
Mm.
everyone in my group and like everyone I know, my parents, me soon enough, don't feel like 55 is actually old.
No.
Right? And so to like
It's the beginning of our life now.
yeah, so to start with saying, we're going to bring in everybody who's 55 and up and tell them, hey, like, you're this old group who should think about one of these, it just became clear that even if that's what the data said, we would waste a bunch of time talking to people that weren't interested in this program, and that we might even kind of upset people. And so that was it was a challenge. And I just had to remind myself that, like, if you're going to do engagement for real, you got to actually listen to the answer that you get, not try to convince them that 55 should have been the right answer. I heard it, and we moved it up to 65.
Sean, what about you? How did it feel as a person who was waiting their kidney transplant to hear about other people's story and discuss the benefits and risks?
Well, by the time that I got involved with it, I had already had my transplant.
Oh.
And but to hear people that were still waiting for that, I was able to compare where I was before and after, and to think about where they were and compare it to where I was and how my life had changed. Now I'm certainly well beyond the 65,
Mm.
and how my life had changed follow getting off of dialysis and having the kidney, and what it was, how restricted it was on dialysis, and how my life has changed since then. So I could bring both perspectives, what it's like to be on and waiting, and being off and having the transplant. And to think about things that way was really pretty important. To put myself in the position of those who are yet still on dialysis, wondering should they or shouldn't they go for a transplant. And
Hmm.
that balance of how much life versus the quality of that life, whatever length it is, becomes much more important than just, I want to live 40 years. I don't need 40. Somebody else might want that, but each person will assess that quite differently, of what they want out of their remaining years, whatever they might be.
I just want to pause there. We have a few audience questions coming in. Paula, one of our patient partners, and who has been very helpful to CHI, asked, "Can you please give some ideas of the different factors that people had to choose from?" And she also wants to know if the patient partners involved have gotten, other than John, which we just heard, have patient partners gotten their transplants?
Um, yeah, so I guess I didn't really define how I recruited people to be in this. I mentioned age and gender in that, but basically, we wanted patients at different stages in this whole process. People that were not yet on dialysis of any kind or
Hmm.
received a transplant, people that were on dialysis waiting for a transplant, and people who had received a transplant. Because sometimes people waiting for a transplant see it as a bit more of a holy grail than it is. And you need the people that have actually been through it to say, you know what, in retrospect, I would have chosen one of those, or in retrospect, this was kind of a lot. I wouldn't want to have done it, for a marginal offer. So that's how we built the program. I'm not really sure, just because I am one of the small group of kidney transplant doctors, that I can really say what happened to the thing. I feel like that involves my FIA and my medical knowledge of them as individuals, which was actually kind of awkward sometimes, because I then went on to become a staff nephrologist with the transplant and would have to provide care. So I can't really comment on it, other than I think that our group experienced the typical group that is waiting for a transplant. Some people
Mm.
got them, some people got too sick to get one, and some people died before ever getting one. And that's the whole point of why we're built a group that way, so that um, we were capturing the reality of what it means to have kidney failure at an advanced age. In terms of the factors that we were looking at, they're concepts. They're kind of the factors that were on that ended up in the decision-making tool that I made. How long the kidney might last, how long
Mm.
you might have to wait on dialysis, the risk that the kidney never works, and the surgical risk involved. Those are the kind of the main four that we ended up factoring into the survey, that had like some trade-offs built into it, because that's the trade-off patients are being asked to make. accept a higher risk kidney now in exchange for getting off dialysis and getting a transplant while you're still fit enough to get one, or wait for a lower risk transplant. And we're trying to kind of determine that inflection point where people would feel like, okay, if I can offer you 3 or 4 years off dialysis, you'll take a high risk kidney. If it's going to be you're at the top of the list anyway and you only have to wait a few months, this isn't for you. And
Right.
I see one more about location and remoteness. Um, so again, when I built the patient partner group, yes. And then when we did the survey, we collected information on distance from dialysis center. I wouldn't say that we had enough power to really um, like officially analyze if that was a factor, but you could tell going through the surveys that the people that live further away want off dialysis sooner. I don't know that you need a survey to even prove that. It's just clearly harder when you live remotely and far away from a dialysis center. And I can say that my second big project that I have done since this one is we have made some changes to how we allocate transplants for people that live very far away. And some of the supportive work for that was the experience of this patient group talking about that kind of organically. It wasn't,
Mm.
it just kind of came up in these and that kind of prompted a second project out of it. So, yeah.
John, how does that make you feel to hear that?
Good. It's interesting because I keep thinking about my experience as being a home dialysis versus center-based, and some people say, well, maybe that's the way to go. But living alone on home-based dialysis was not so easy. So looking at these remote individuals who might even be able to do it from home might be another avenue to look at too. So it's I think the choice of the people that Aaron had was really quite good and reflective of what's out there and
Mm.
who we are and what are the things we have to consider. And it varies from person to person, whether you're single or married or remote, First Nations, economically advantaged or disadvantaged, on and on and on. So the broader collection that he had was really quite useful, I think.
Thank you. Reflecting on what you learned from one another as a researcher and a person with lived experience, what advice would you give to others who want to engage patients and families in similarly complex or sensitive research?
John, you can go first if
I
you
was
want.
going to say you go first.
Okay. All right,
Any
sure.
advice?
Yeah.
Uh, what advice? I think to really learn to listen and hear and make sure you understand as you ask for information, as opposed to just jotting it down. Probe the
Mm,
question while the answers are coming, and be sure that you're clear on what the message is that's being given, and go from there. And I think Aaron did a really nice job, including everybody, calling on individuals as well. Um, One of the things that sometimes work with groups and meetings is to call upon even the least responsive person first to bring them in as opposed to setting them aside. Um, so I think he did a wonderful job in making this happen. So
mhm.
maybe consult Aaron to figure out how he did it. If you want to set up your own, bring him in as a consultant.
Mhm.
Thank you. I mean, I had no experience in this before. I don't think I'm actually particularly skilled at it. I read I read some, studies about the different ways to do it, the different levels of engagement,
Mhm.
and I just really had to actively check my ego. Like that was legitimately what it was.
Mhm.
Like I when I was doing this, because this was a research fellowship year before I started my like staff attending job.
Mm.
Probably when we were doing these meetings, I may have been one of the people in the country or like at maybe a specific moment in time, the world that knew all this data so well. I'd read all the papers, I was reading them every day, I knew it, right? But if I wanted to actually get out of the engagement what we were looking for, I needed to just accept that that's only one way of knowing something
Mm-hmm.
and just check that there and listen to the answers. And if you weren't going to listen to the answers, this was a waste of everybody's time, including mine. And it was, you just had to go in humbly and brace yourself for answers that you don't want. Like the age thing, I didn't want that to be the outcome, but it was, and actually it has worked very well. And so my advice would be like if you're gonna do engagement, do it for real. Don't just do it because it's a checkbox on the grant. And don't
Mm-hmm.
just have your partners, proofread the survey you built in its entirety, because that's just kind of a waste of everyone's time.
Right. And what you both are pointing at, listening, checking ego, reading, coming in at this engagement in a serious, thoughtful way, seems intuitive, seems easy, but it often is the hardest thing to do, especially if you see yourself as an expert. If you could summarize what this experience has meant to you in a single word or phrase, what would it be?
Can't do a single word because, but
A phrase.
uh, I think it just really helped me remember that the collective is made of individuals. And
Mm,
it's really changed the way I practice medicine. I have mainly a clinical job now. I don't do a ton of research, but what I learned about like listening to the way that people make decisions and factoring in all these intangibles that are not in, table one of the randomized control trial. The
mhm,
stuff John mentioned, like, do I live alone? How do I think about my life? Am I someone who wants 10 or 20 more years of life, or do I just want five? Like these are things that are difficult to talk about and difficult to capture in like
mhm.
evidence-based medicine, and that has spilled over into how I approach my patients. So, yeah, just like, research on the collective matters, averages and stats and all that, we couldn't do without it, but those are all individuals.
I think your one word may be human-centered. Care.
Sure, we can use that.
John?
For me, it added a sense of purpose to life to be able to be part of this, which is more difficult to find sometimes as one gets older.
Mm,
So, why to do things? I'm a patient participant on another research project, and I feel like I'm there because somebody's ticked a box. There is little interest, questions towards me at all. So, it might have helped secure the grant, but I think I'm being underused. In this other
mm,
project with Aaron, I feel part of it and
mm.
engaged in it and wanting to help it go. The other one that I'm on, if it does, fine. If it doesn't, fine. They really don't seem to need me.
Thank you. I'm I'm feeling emotional by just hearing how effective this experience was for both of you and how it's changed your perspective as a physician and as a patient. We have a thank you so much, Dr. Bonds and Trachtenberg. This was an exceptional and thought-provoking discussion from the audience. Um, I just want to take a minute just to open it up to the audience in case there's any more questions before I do my summarizing thought. And again, if you just, we have a question about the timing of dialysis, but I think that we're going to stick to the topic of patient engagement for now. Um, I would like to say thank you. Thank you to both of you for sharing your time, your honesty, and your wisdom. I think that your experience reminds us that engagement isn't just about improving research. It's about deepening our collective understanding of what matters most to patients and families. Thank you so much to our speakers and for all those people who took the hour out of their day to attend our session. You will receive a follow-up email with further information on how to access the slides and recordings. We also, sorry. Sorry, we have for, more. This is very helpful and impacting. Thanks for sharing. Thank you so much for all the good work that you're doing. Uh,
And I just want to say thanks to CHI and the prep award. Like that was none of this would have happened without that. So
gr-
thank you.
Great. We also had a patient partner said you can try when you're on being a patient partner and feel like you're not being heard, you can just say whatever you think and be loud so they can't help but hear you. So she is encouraging you to use your voice um, and make sure that they hear you. Um, and going back to my closing, sorry about that. We welcome your feedback for the session. You will get a prompt when you close, asking you to complete a short survey following the closing of the webinar. This is very important and very helpful for us. So please take that minute to fill it out. We'd also like to invite you to join us on January 2026 in the new year for our Pal with Patient Engagement Consultant Susie McLeod, who will share how to draw out experiential knowledge by asking the right questions in patient and public engagement. Susie has over 30 years of experience in community engagement across the healthcare system and is currently engaging patients, families, and the public for CHI. We will be sharing the registration link with you and hope you can join us. I have learned so much from Susie, who engages in the most brilliant way. And thank you again. We hope that you are walking away encouraged to further explore the possibilities of patient engagement in your work. Thank you. Thank you.
Thanks, everyone. Great to see you, John.
Likewise, glad to connect even virtually.
And
thanks for letting me be part of this. It's been great.
thank you to the audience for being so engaged.
I'm assuming we're off.
We are off. I'm going to end it right now.
Good.
Bye.
Thanks lots. Take care. Bye-bye now.